Okay, so before we get started, I'll just do a quick land acknowledgement. The University of Calgary, located in the heart of southern Alberta, both acknowledges and pays tribute to the traditional territories of the peoples of Treaty 7, which include the Blackfoot Confederacy, comprised of the Siksika, the Piikani, and the Kainai First Nations, the Tsuut'ina First Nations, and the Stoney Nakoda. And the city of Calgary is also home to the Métis Nation of Alberta, districts 5 and 6. So this year we wanted to highlight the work of our Catalyst Grant awardees, and I believe that Dr. Leslie Skeith was successful in the first round of this award. So we're happy that she's here to share some of her work. So Dr. Skeith is an associate professor in the Cummings School of Medicine, in the Department of Medicine. She's a member of the Libin Institute, as well as ACRI and the O'Brien Institute for Public Health. She is an adult hematologist with a research focus in preventing VTE during pregnancy and postpartum. She also studies antiphospholipid syndrome and VTE risk with exogenous hormones. And she has an assistant here today, or I believe a trainee, a second-year internal medicine resident, who is Dr. Hannah Yang, and she is at the University of Calgary. So they're going to double team the talk today.
Thank you for inviting me to speak today. Hope we can hear. Zoom is on. Yeah, perfect here. How to get started. You can just click on, click there. Okay, perfect. So myself and Hannah will present on prevention and management of VTE in transgender and gender diverse individuals. And I'd first just like to acknowledge the importance of language. This is supported by the UCalgary Women's Health Research Series and Catalyst Grant Project. And I borrowed this great term from Dr. Karen Nuremberg, the terminology of Women Plus, really intended to be inclusive of all genders and represent gender-related roles often associated with caring for young families. I aim to use person-first inclusive language in this presentation, and please feel free to contact me if you notice anything that can be improved. And here are our research disclosures. This slide is usually at the end, but I just want to really acknowledge the importance of our team. I've learned a lot about hormones and transgender and gender diverse individuals with Natalie Sad, Lorraine Lau, as well as Shannon Bates from McMaster University. And this project includes Natalie, Lorraine, Deepa, Shannon, as well as statistical support from the Libin Motzel Core Analysis Lab. So there are many different roles or indications for hormonal therapy, exogenous hormonal therapy, as listed here. And what we'll spend some time today is actually the first three. I do want to also cover contraceptive therapy and replacement for deficiencies, for hormone replacement therapy for cisgender individuals, because this is actually where most of the data is, and we extrapolate a lot and compare it when we talk about gender-affirming hormone therapy for TGD or transgender and gender diverse individuals, really to put it into context. So I'll do a brief overview of the first two and then focus most of my time on overview of the literature, and then our resident Hannah will showcase our preliminary results of our research study so far. So when we focus on contraceptive therapy for cisgender individuals, this is a combination of estrogens and progestogens. The Options include combined hormonal contraception, which is both an estrogen and progestin with the pill, transdermal patch or vaginal ring, or progestin-only options with a low-dose progestin-only contraceptive pill, an intrauterine system, IUS, also known as IUD or device, injectable DMPA, the trade name of Depo-Provera, and subdermal implants. And when we see progestogen, it's a little high up, but this is a combination of physiologic progesterone and synthetic progestin. So most of my talk, I'll be using the word progestin. So thinking kind of background risk, in young people, the risk of thrombosis is 2 to 3 people in 10,000. And the relative risk of a combined oral contraceptive is 3.5 times more with COC. But in a big picture, this risk is overall low when we think of the absolute VTE risk, around 5 to 15 people in 10,000. Risk factors with the additional VTE risk with combined oral contraception includes higher estrogen dose. The earlier first generation doses had a higher thrombotic risk. We now often use 30 to sometimes 20 micrograms of estrogen. Later progestin generations, which may have other side effects or other benefits of use, but the later generations, third and fourth generations, do carry higher thrombotic risk. And the shorter COC duration, those who start within 3 months have the highest risk, but longer, the risk still does persist in a small way. We know that there are added additional risk factors that may also increase the risk, having a inherited thrombophilia, a mild thrombophilia like heterozygous factor V Leiden or prothrombin gene mutation, would have a lower numbers, as you see, 0.5 to 2 per 100 pill years, compared to a more potent thrombophilia, where we would definitely want to avoid for those with antithrombin, protein C or protein S deficiency. And we have established literature for age, obesity, smoking, immobilization, fracture, with the contraceptive therapies. What do we know about progestin-only contraception for cisgender individuals? Based on meta-analysis data, the low-dose oral progestin-only and the IUD or IUS do not carry an additional thrombotic risk. With a caveat, as we had a recent database study last month published, which, there's a possible small risk with the low-dose oral contraceptive progestin-only therapy. So a little bit of a caveat, but overall, all of our other data suggesting no added risk. But we actually do see thrombotic risk with the DMPA injectables, and this recent publication confirming a small but definite risk with the subdermal implant, which maybe is smaller than other options and more, further discussion needed. What about the recurrent thrombotic risk? So if you've had somebody who's had a hormone-associated VTE, they stop anticoagulation after a treatment period, and they stop contraception, what's that risk of recurrence? Overall, that risk of recurrence is low. In a recent meta-analysis we published of 19 prospective studies, this is 1.2 recurrent VTE per 100 patient year. But are there higher risk groups? Do those added risk factors matter? We did a subgroup analysis of this study called the reverse cohort, which was the derivation of the HER2 risk score. And we looked and divided people whether they were COC users or non-users, whether they were low score or high score, depending on age, BMI, a specific Vitus D-dimer at half the cut point, or leg symptoms. And we did see that those who had a high score for COC users did have more of a recurrent VTE risk, 3.5%, compared to the low score, 0.4%. But this was still lower than that, clearly unprovoked non-user group of 6.1%. So you can see that there are different factors that come into play when we have these discussions. I think some key data that really guides our use in the transgender population is that we do have data in this area for the cisgender contraception to support safely continuing hormones while on anticoagulation. It does not increase the risk of thrombosis. When stopping anticoagulation, there is a recurrent risk of 2.4 to 4.6-fold if you continue hormone therapy. Once they are stopped, the hemostatic effect in the blood resolves around 2 to 4 weeks, so it does take some time, but does gradually resolve. And as I mentioned earlier, the progesterone-only IUD and pills are not associated with recurrent thrombosis. What about hormone replacement therapy for cisgender individuals? This is a combination of estrogens and progestogens. And the role of the progesterone is if there is someone with an intact uterus to avoid the only estrogen exposure to minimize proliferation and associated cancer risk. And the options could be oral or transdermal for the estrogen component, most commonly the 17 beta estradiol and different formulations, but there are others. And then the progestogens tend to be the oral route. And there are different types of progestogens, the micronized progesterone or the different derivatives. So it gets a little bit complicated when you think of all those combinations. When we think of initial VTE risk with hormone replacement therapy, what is different is that baseline thrombosis risk is higher. Somebody who is older compared to that 2 to 3 people per 10,000 patient year, we're now up to 16. So even though the hormone replacement therapy carries a lower relative risk compared to contraceptive therapy, the absolute risk may be the same or higher because you're starting from that higher baseline risk. We do see a thrombotic risk with the oral, both estrogen alone or combined. And it also depends on the progestogen and that micronized progesterone and most pregnating progestogens do not appear to increase risk, but others do. So, there is some nuance there. And overall, what we have is that the transdermal estrogen alone and combined do not increase the risk of thrombosis with the transdermal approach for hormone replacement therapy in cisgender individuals. When we think about recurrent VTE risk for hormone replacement therapy, we have a randomized controlled trial for postmenopausal women with prior thrombosis, prior VTE, not on anticoagulation, who were randomized to either the oral hormone replacement therapy versus placebo. The trial was stopped early due to excess VTE events, 10.7% versus 2.3%. And there were similar findings in another RCT. What we know is that transdermal estrogens do not appear to increase this risk, but we have less data in this area. So over 1,000 postmenopausal women with prior VTE not on anticoagulation were followed and compared users of hormone therapy, which is around 130 people. It wasn't that full group versus non-users. 22% had unprovoked VTE, and it was that oral estrogen that did increase the risk of recurrence, and the transdermal estrogens appear to have no added risk. I say appear, this is one study. We have the wider confidence intervals, and these were small numbers. So overall, we do think the oral does increase risk. Transdermal estrogen appears not to increase risk for hormone replacement therapy for cisgender individuals. All right, so with that, now focusing on, on our talk of transgender and gender diverse or TGD individuals, there's a lot of terms, and I'll just highlight what we'll use in the talk today. We'll focus on trans feminine individuals. In the literature, this is also, there, different terms, but transgender women, individuals assigned male at birth who identify as female. This is the focus of feminizing hormone therapy, which is a combination of estrogens and anti-androgens. Progestins may be added on the individual basis, but are not recommended in guidelines. Transmasculine individuals or transgender men are individuals assigned male at birth who assigned female at birth who identify as male. And this is the focus of masculinizing hormone therapy, which is really the focus of testosterone. But really also, there's so much complexity because you can also use estrogen and progestins or progestin-only options for menstrual suppression and or contraception. So we also have to keep this important piece in mind. So here are, we're talking about many different agents. We have estrogens. Most commonly is the 17-beta estradiol, similar to hormone replacement therapy for cisgender individuals. The ethylene estradiol, conjugated equine estrogens are no longer recommended, but there's others, sublingual, transdermal, parenteral, as well as the oral. And anti-androgens, and there are different types of anti-androgens. For example, spironolactone, would have no progestogen activity, whereas others, as you see here, may. And as I mentioned, progestogens may also be used, kind of individualized basis. There's a lot of limitations to the literature. This is mainly because we're basing our data from retrospective cohorts that really focused on the TGD, clinics, populations, often from the endocrine side, reporting all side effects or all, information on efficacy and risk. And thrombosis usually was not the only focus. And because of that, most studies did not standardize VTE rates to person years of follow-up and may just have a line in the paper saying, how many people had thrombosis. And as I mentioned, there's lots of different drug formulations and different dosing. So it's really hard to judge or compare, for example, a cohort with 17-beta estradiol plus spironolactone. How does that compare to an estradiol valerate cypertron acetate study? Because both the estrogen and the anti-androgen and dosing differ. So it's quite messy compared to our previous literature that I reviewed. What we know so far for initial VTE risk is from a systematic review of 22 studies. For transfeminine individuals, this is 42 per 10,000 patient years. Transmasculine individuals, 10 per 10,000 patient years. Transfeminine individuals had a higher thrombotic risk compared to cisgender women or cisgender men when matched to cardiovascular risk factors or prior events. This is similar to higher risk, more comparable to a cisgender women using HRT. And the hormone type matters. When the hormone regimens first came out, the first publication from a cohort starting from 1975 onwards, they used oral ethylene estradiol 100 micrograms per day. And this, for example, for COC use would be starting at 50 micrograms per day, and we now use 20 to 30. So over time, we saw these higher thrombotic rates upwards of 6%. And from that, there was a change in practice where this, for example, this clinic in Europe changed to a transdermal estrogen for those greater than 40 years of old in 1989. And it was just one cohort after another to see this change with the annual incidence of ET of 0.4%, 2.6% in the first year of initiation. So it did, or we have seen some lower rates with more recent changes to regimens. One of the largest studies is a retrospective study of 676 transgender women who received oral 17-beta estradiol and spironolactone. And this was quite reassuring, 7.8 per 10,000 patient years, or one person who developed a thrombotic event. And the studies, although small, that reported transdermal estrogen, so far we're seeing no or a very small number of VTE events reported. But all retrospective cohort studies of varying, different reports. The literature is very sparse for inherited thrombophilia and other VTE risk factors. We really extrapolate from that cisgender population. There were 251 individuals who were screened for thrombophilia. 7.6% were positive. No patients developed thrombosis. I would say in most cases, screening for inherited thrombophilia prior to hormone initiation is not recommended. And we have less data for the other VTE risk factors. Seems to be similar to those with cisgender individuals. What did the guidelines recommend for the Transgender Health 2022 guidelines? That transdermal estrogen for eligible transgender and gender diverse people at higher risk of developing VTE, so they're using an age greater than 45 years or previous history of VTE. And this is similarly echoed from the Endocrine Society, those older who may be at higher risk of thrombosis to consider that transdermal preparations. They also make specific comments on certain injectable estradiol preparations. I think some practical guidance that I would give when I see a patient is to use the lowest effective hormone dose that we know. So it's lots of discussion with our endocrine and transgender physician or medicine physician discussion, considering the transdermal estradiol for those with risk factors. And there's lots of mixed opinions and almost no data, but we do not need to stop hormones around surgery. This is more of an opinion, but to consider added thromboprophylaxis rather than stopping and starting. And the management of a hormone-associated VTE, if somebody comes with thrombosis, we can continue hormones as long as they're anticoagulated. This is a really nice toolkit, a blood clot toolkit that the North American Thrombosis Forum has published online. And a really important key take-home message is the key thing to take away from all these resources is that the risk of blood clots is and should not be a barrier to gender-affirming care. We should be supportive, and that may include anticoagulation or ongoing discussions, but a key message. Lots of great videos and information for patients. I just have a couple of slides on testosterone and thrombotic risk. We have a recent New England Journal publication, a randomized trial for testosterone replacement for hypogonadism does not increase VTE risk in cisgender individuals. We know from kind of lab testing that physiologic levels of testosterone does not impact hemostasis levels, but supraphysiologic testosterone therapy has been associated with decreased fibrinogen, increased hematocrit. But what actually that means from the patient and clinical perspective, we don't know. But there is a potential that maybe there's more or higher potential doses of testosterone, so something to keep in mind. We have less known for transmasculine individuals. A meta-analysis of 13 RCT showed no added increased VTE risk. And we have more uncertainty for the cardiovascular risk and other factors that may contribute. In one meta-analysis, stroke was 0.8%, myocardial infarction 0.6%, wider confidence intervals, whether they're higher or not compared to cisgender women. So more uncertainty here in this population. A recent publication showed that high hematocrit is rare with exogenous testosterone use in GAHT. Over 6,000 individuals, less than 1% had a hematocrit of 0.54% or greater. It was higher for transmuscular injections, and both root and testosterone levels did have association with hematocrit after controlling from this one study. All right, so what our focus now, kind of moving a little bit more into the research study is, and this is in progress, we will share, is another retrospective cohort study, but really evaluating our current practice patterns for Calgary-specific data, Calgary-specific practice patterns, and to determine the feasibility of a future multi-center study. Can we expand to other Canadian centers? As part of our cohort, which will present some preliminary data on, it's also important to think about feasibility for future grants. What's the time, things like REB approvals, AHS approvals, consent process review in a more sensitive population. And so this is the fastest, good job, Hannah, the fastest submission to approval of 14 days with our ethics committee. That I think is unheard of. That's amazing. Time to approvals was 2 months, and we did get a waiver, with very careful use of data and privacy, waiver of consent for a retrospective chart review. I think also important to acknowledge what our thrombotic event rate is in a young population, and also understanding for that future larger study, different clinic structures, at different universities, institutions. So more work is needed, but some early preliminary feasibility data. So with that, I'll turn this to Dr. Yang, who will talk more about where we are so far.
Thank you so much, Dr. Skeith. So I'll be presenting on the methods of our study as well as some of our preliminary data. In terms of our primary research question, we wanted to look at the cumulative incidence of both venous thrombotic events, but also arterial events among the TGD population in Calgary. And specifically, we partner with the adult gender health program here in Calgary, which I'll get into more a little bit. In terms of our secondary research question, we also wanted to look at the frequency of individual VTE and arterial risk factors, the types and formulations of hormones that are used for gender affirmation in local practice. And we also wanted to look at the cardiovascular screening patterns, like the frequency and the types of testing that is done in this population. For our study, we performed a retrospective chart review looking at historic SCM patient charts starting from the inception of the adult gender health program in Calgary in 2013, which is a multidisciplinary clinic here in Calgary up until December of 2024. We included patients who were 18 years of age or older, were seen at the gender health program, and were receiving gender-affirming hormone therapy. We documented the presence of persistent VTE as well as arterial risk factors, and we also documented transient VTE risk factors that people will develop while they were on hormone therapy, which I will define later on. Our primary outcomes of interest were the incidence of diagnosed venous thrombosis as well as arterial events. In terms of the data that we collected baseline demographics such as age, height and weight, BMI, and prior medical conditions that were relevant to their risk profile. For instance, we included medical conditions that were known to increase bleeding risk because this would also influence how we manage anticoagulation. We recorded the types, formulations, and doses of gender-affirming hormone therapy, including the timing and duration of treatment. We collected information on when anticoagulation was prescribed, the types of anticoagulants used, and whether they were used to prevent or to treat thrombosis. Our outcomes of interest were venous thrombotic events, which we defined as deep vein thrombosis in the proximal or distal limbs, pulmonary embolism, superficial vein thrombosis, and unusual site thrombosis in non-limb sites, such as splanchnic vein or cerebral vein thrombosis. For our arterial outcomes, we looked at myocardial infarctions, ischemic strokes, TIA, and peripheral arterial disease. We're still in the process of data collection, but our plan for future statistics is to report our primary outcome as a cumulative incidence per patient years with 95% confidence intervals, and further subgroup analyses that we will look at also include the associated hormone therapy and the presence of additional VTE risk factors. At this point, we have completed 273 charts out of 374 charts. So we are 72% of the way there. 25 of those charts were excluded. And the most common reason for exclusion would be a lack of clarity about the hormone dose or the type, lack of follow-up, or just general lack of documentation for our purposes. Of the charts that were included, we were able to capture 146 transmasculine individuals, or those who were assigned female at birth, and 102 transfeminine individuals who were assigned male at birth. When we looked at the baseline characteristics of our population, we tried to group their medical profiles into those that would increase thrombotic risk or persistent VTE risk factors, and those that were more so associated with arterial risk. So our persistent VTE risk factors included smoking or a history of smoking at the time of starting hormone therapy, previous family or personal history of VTE, active or recently treated cancers, known diagnosis of thrombophilias, and a few other conditions which are shown here. I wanted to highlight that we had one case where there was a known diagnosis of thrombophilia, which was a case of a heterozygous factor V Leiden mutation. The arterial risk factors that we documented are shown here, and the most common conditions that we saw were dyslipidemia, hypertension, metabolic associated liver disease, and type 2 diabetes. Not included in this table, but we did also report on apolipoprotein B and lipoprotein A levels if they were available, because this would also contribute to someone's cardiovascular risk profile. We also commented on the presence of atrial fibrillation and prosthetic heart valves, as this would also influence anticoagulation. The transient VTE risk factors that we documented include surgeries, which we broke down into gender-affirming versus other types of surgical procedures, hospitalizations for an acute illness, which we defined as minor immobility if they were hospitalized for less than 3 days, or major immobility if they were hospitalized for longer than that. We collected information on pregnancies and C-sections, leg injuries with consequent reduced mobility, long-haul flights, and multi-system trauma. For each case of a transient risk factor, we also wanted to document how their gender-affirming hormones were managed around that time, and if they were placed on prophylaxis for venous events, including both chemical prophylaxis or mechanical measures. Moving on to the types and formulations of hormones that we see used in Calgary, starting with the use of feminizing hormones. So individuals are typically prescribed estrogens, progesterones, anti-androgens, or any combination of the above. And as you can see, the most common combination we see is typically estrogen with an anti-androgen or estrogen alone. If we look at the different types of formulations that are used for estrogens, here we have the various formulations depicted on the y-axis, and on the x-axis, we have the frequency count of prescriptions for estrogen initiation. So each count represents a new start of that type of hormone, and this is relevant because individuals often switch between different types and different formulations depending on their preferences and their desires for gender affirmation. So each count is not equivalent to a head count. It rather captures each time there's an initiation or a reinitiation of that formulation. Here you can see that the most often prescribed estrogens that we see are the transdermal patch and the oral estrogen forms. If we look at the anti-androgens we have available, there is cyproterone, finasteride, and spironolactone, and we definitely have seen more spironolactone prescriptions than the other two. For the progestogens, we have medroxyprogesterone and prometrium, which are shown here. In terms of the testosterone hormones that are used for masculinization, we have oral, transdermal gels and patch, as well as intramuscular or subcutaneous injections, including testosterone enanthate, cypionate, and other formulations. Most commonly, intramuscular or subcutaneous injections are prescribed, and in Calgary, we most frequently use the testosterone enanthate or cypionate. In terms of the primary outcomes that we have collected so far, we have found 0 arterial outcomes in the transmasculine cohort. We have found 2 cases of venous thrombosis thus far amongst transfeminine individuals. Interestingly, both of these cases were deep vein thrombosis that occurred while on oral estradiol. In the first case, unfortunately, we don't have a lot of information around the actual diagnosis or management, as this happened to an individual who was in the United States, but it was deemed that this thrombotic event was provoked by the oral estradiol. They were 34 years old at the time of diagnosis, and they had a BMI of 33 at the time. They were not continued on long-term thromboprophylaxis, but they were switched to transdermal estrogen for ongoing hormone therapy. In the second case, this venous thrombotic event was also felt to be provoked by a combination of the oral estrogen in addition to immobility from a leg amputation. This individual was 45 years old at the time of diagnosis, and they were taking a dose of oral estradiol at 3 milligrams daily, in addition to spironolactone, which is one of the anti-androgens. This patient did not want to have ongoing thromboprophylaxis and instead wanted to try conservative measures with physiotherapy and improving their mobility. They were, however, switched to transdermal estrogen as well. For their acute clot, they were treated with warfarin for 6 months, the choice of warfarin because of renal dysfunction at the time of diagnosis. So these are some of the preliminary results that we have so far. We still have a few hundred charts to review, but looking ahead and beyond for our future directions, ultimately with our project, we really want to continue building towards a framework that supports person-centered risk assessments within the transgender community and to help enable informed decision-making between clinicians and patients about gender-affirming hormone therapy, the risks of venous and arterial disease, and to help come up with strategies to mitigate these risks. In order to provide comprehensive thrombosis risk assessments, we need to better understand how the types and formulations of hormone therapy impact this. We know that there are differences in the incidence of cardiovascular disease and other health conditions between biological males and females, but are there also baseline differences between the transfeminine and transmasculine cohorts? And how do we reconcile this in the presence of exogenous hormones? As we age, the risk of arterial and venous events also increases. So how is this risk impacted if someone is also on hormone therapy? Another interesting area we wanted to consider is the perioperative management for gender-affirming surgeries. How should we be managing hormones as well as thromboprophylaxis in these types of situations? In terms of management and risk reduction, how often should we be screening for cardiovascular disease amongst transgender peoples? Should our approach to risk reduction be different between transfeminine and transmasculine? For example, in people who are taking testosterone, should we be considering prophylactic phlebotomy and antiplatelet agents for arterial risk reduction? And for venous risk reduction, what is the role of primary or secondary thromboprophylaxis? And finally, we also wanted to look at and explore the reasons for referrals to hematology and thrombosis in order to better understand the current systems in place and to continue finding ways to better provide care for this population. That concludes the end of our talk. Thank you so much, and we look forward to hearing your feedback.